today, I'm so excited to have Maureen Bisognano. Am I saying that name right?
Fine.
Yes. With us today. She's a great speaker. She's an expert in her field, and it took some organizing, but I'm so glad to have her here. It's her first time at the iLab as well, so I'm glad that she got an opportunity to look at what we're trying to build here. So if you guys aren't familiar with Maureen's work thus far, she is the current president and CEO of the Institute for Healthcare Improvement. And before that, she was with the same institution for 15 years as the COO, correct? Mm-hmm. So with that, I'll just hand it off because she has a lot to share with you, and I hope you guys enjoy the evening tonight.
Thank you, Alice. Thank you. Well, I am so excited to be here. First of all, to see some friends and familiar faces, and second, because I got a little tour of the iLab. And for those of you who don't know about the Institute for Healthcare Improvement, we are right across the river, right in Harvard Square next to the Charles Hotel. And we have some parts of the Institute that look like the iLab. Some parts look more traditional. But if you ever are wandering through Harvard Square and you get the opportunity to stop by and visit, we would love to have you. How many of you have been to visit IHI? Yeah, a couple. And so you can perhaps give a virtual tour. But the Institute is made of, comprises about 130 people, and we work worldwide. Our mission is huge, to improve health and healthcare worldwide. And obviously, 130 people can't do that directly. So I'm going to show you how we work on innovation and spread and use leverage to get that mission accomplished. So that's our staff. This is our board of directors. And I think the reason I put this slide in just is to give you a sense of the diversity. The healthcare problems that we're looking at in healthcare today are huge. The gaps are many. We're spending $2.7 trillion in the United States on healthcare each year, and about 75% of that is going to chronic disease management, and all of the metrics in chronic disease are going in the wrong direction. So what we're doing is trying to close some very big gaps, and we're doing it through working through research and science. Some of our board members are working with data, big data, and working in academic settings. Some are working in clinical settings like Brent James and Gary Kaplan at Virginia Mason. Some are working directly with the public like Helen Haskell and Jenny Chin Hansen, and Nancy Snyderman, you may recognize her face as the voice of NBC. She's an oral surgeon, but she's the person who relays healthcare to the public through NBC. So this is our mission, as I said, to improve health and healthcare worldwide. And we do it in a couple of different ways, but the way I wanted to talk about tonight is these concentric circles down here in the bottom. How do we think about innovation? Because we're here in the iLab. So the way that we work looks like this. Every 90 days, we have a big pipeline, a wall just like these walls, where anybody walking through can add a problem to the pipeline. What's up there now is how do we ensure breastfeeding in the first hour of birth to create the whole reliable birth bundle. And what we're finding is that it's very different in low and middle income countries than it is here in the United States, but the diversity still exists. We have somebody who came in from New Zealand and said, how do we decrease reliance on blood transfusions after joint surgery? We had somebody from Kaiser Permanente come in and say, all of their complications are decreasing except aspiration pneumonia. Are they feeding patients too early? Are they over-sedating them? Are they not positioning them effectively for feeding after surgery? So we have projects of all kinds. That's where the notion of the triple aim came from. What we did in our work was look at, when talking to healthcare leaders around the world, some of them said, we're working on improving experience of care, making it safer, making it more patient-centered. Some said we're working on health, working on public health and health issues. And some said we're working on cost. But we couldn't find people who were working on all three. So we labeled the problem. We called it the triple aim. And we said, we need healthcare leaders We need people from the business school to step up and say, we will solve all three problems simultaneously. Because when you get the School of Public Health working on one problem, the medical school working on another, and the business school taking a third approach, we're actually creating more complexity and more silos than we're solving. That's where the notion of bundles came from, ventilator bundles or central line bundles that have so dramatically decreased complications. So anybody, any of you who have an idea can throw that idea into the pipeline, and every 90 days we pick 5 to 7 of those problems. We assign a team, a physician, a nurse, research associates, and they go into the field and they create a template for that 90 days. We then share that with the second ring. Those are our strategic partners. The Indian Health Service here in the United States, Kaiser Permanente, Premier, the Catholic Health System, the country of Ghana, the country of Malawi, an organization in New Zealand that I'll be visiting next week called Ko Awatea. And so any idea that we get in the middle ring, we can then deploy and hit hundreds of organizations but with about 15 phone calls in that second ring, because those second ring people have leverage. They've got relationships. The third ring is building capability, programs, courses, virtual events, seminars. And the last ring is our little radio studio, which you'll see if you come over. It's called WIHI, and we have a little radio broadcasting studio. We hired the Madge Kaplan, who's the NPR's health reporter, and she did a radio program today on mobile vans. And our team, the IHI team, in our diversity and inclusion work, has adopted the idea of mobile health vans for patients who have socioeconomic challenges and can't get access through the normal delivery system. And so they've adopted the mobile vans, and we, Madge interviewed the, anybody hear it? We had about, do you heard it? We had about 1,100 people from all over the world learning about how do you bring care out to patients when they don't have access to transportation to get to a hospital, or they don't have insurance to get covered. So the other thing that's in the outer ring is the IHI Open School. And that's a resource that how many of you have looked at the Open School? That's a way for you all to learn improvement skills, leadership, patient-centeredness, safety, all for free, all virtual, and you can just go on to ihi.org and enroll in any of those programs for free. So it's how 130 people can take an idea from the inner ring and reach millions of people every year in the outer ring. Let me just stop and say, do you have any questions or reactions to what I'm saying? And if you do, stick up your hand, and then we need to get a mic to you just for amplification. Sam, do you have a question?
No, it sounds brilliant. I want you to keep going.
Okay. Yes, sir.
What is your response to, and I say this from personal experience working in mental health care and also selling health insurance, I think there's a fundamental problem. There are not people in the healthcare system that are in place that allow patients to navigate the healthcare system effectively. And there needs to be healthcare navigators, because it's there's definitely a lack when patients get out from either a physiological disease or malady, or a psychological disease or malady, and there's no one there to help them form a path forward and set up the continuum of care, or even to make sure that if you get diagnosed with a chronic condition, or God forbid something like cancer, that doctors and your healthcare professionals are adhering to all the clinical standards of care, and this is fundamentally lacking.
You're raising a huge problem, and I do agree with you that the system right now is designed around what Susan Edgman-Levitan from Mass General would call what's the matter medicine. So the physician will say, what's the matter? And depending on the response, they'll either prescribe or they'll refer. And then you end up in this morass of trying to make care sane and intelligible and patient-centered. And what I'm promoting is that we move from what's the matter medicine to what matters to you medicine. And if you're okay, I'm going to come back to some examples that will show exactly, it will show some ideas and some models for navigation that I think are really promising. Yes?
Thank you. I can't wait for the rest of the presentation. I was curious to know, I mean, it seems sometimes the most commonsensical things are so innovative. Your triple bottom line approach, how have you seen others respond to that in the field? And has that been sort of making waves around how others are approaching some of these problems?
So the triple aim, when we first drew the triple aim, we drew a triangle, and we said, who wants to work on health? Who wants to work on care experiences, like hospital improvements? And who wants to work on cost per capita? And the response across the United States, and actually in many other countries, was, I'll take that part of the triangle, or I'll take this part. But even leaders from Kaiser Permanente and other integrated delivery systems, they were putting their emphasis on one part or the other. So what we ended up doing was we put a black dot in the middle, and we said, that's the role of an integrator. And it's a new role. It's not something that most hospitals or most public health officials or most economists are able to manage, because it requires a new convening capability and a new set of skills. And people are now stepping into that role, but it's very clear. I'll give you an example. We're doing some work with a community health system in Memphis, Tennessee. And the hospitals would be in the room, and they would be working on diabetes care. And the patients weren't getting any better. African American men in Memphis were not getting tested for hypertension. There was lots of myth and lore about what happens if you get tested. The chances that you're going to be hypertensive are high. You're going to be put on medication that's going to make you impotent, so nobody would go to the doctor. Nobody would really engage with the medical system. So we brought in the church health service. And what we found is that the ministers, when they came into the room, had a totally different perspective on this. They said to the doctors, you see these patients twice a year for 15 minutes. I see them twice a week for 2 hours. So the ministers said, we'll take diabetes. You guys can work on something else. And they started, when the patients come in for their dinners like this, they started serving healthy meals on smaller plates. And they said in the sermons that there's something about the sanctity of your health. If you want to be a parishioner in this church, if you're a member of our community, you have to take care of yourself. And now you start to see the metrics move. Whereas adding more 15-minute visits is going to do nothing to improve care for those patients. Okay, let's take one more question, and then.
I just had a question about the design of the circle. Is there a way for things to feed back in as well? So say,
oh, yes.
Say there's a problem and someone's already got an innovative solution, one of your partners, or does that come back in as well?
Yes, we have a process that the Swedes say, the Swedish people that we work with say, if you want to harvest, you have to go to the field. So we're always out in the field, and we're out looking for the best ideas. And then we bring them into the inner circle, create a change package that is replicable, and then we spread. As a matter of fact, I'm going to bring you an example from another country. But I'm in other countries doing harvesting quite all the time. All of us are at IHI. That's a very big part of our work. So the 90-day cycles look like this. The first 90 days, we'll put a team together, they write a charter, and they focus on looking at literature searches. They typically go outside of healthcare. They visit best practices in healthcare to do some harvesting, and they create a framework. An example was we had lots of hospitals that had terrible barriers in operating room flow. And so I put together a team and said, I want you to go solve operating room flow. So they came back to me in the first 90 days and they said, we need to go stay at the Marriott Marquis in Times Square for a weekend. So I said, really? And they said, yes, we have to. Because they said, there's nothing in healthcare that looks like the kind of flow that we see in the busiest hotel in New York City with room service, 24 hours a day. You never know who's going to order what at what time of day, and yet reliably they can get it to you there in less than a half an hour, and the quality is good and the waste is down. So they said we have to go stay in the Marriott Marquis. So that's it. Really, it was a small price to pay for the model that they came up with. So they went and stayed at the Marriott. They went in with a hypothesis about how do you manage flow, which was totally blown up by the Marriott. Nothing was the way that they thought it was going to be. They anticipated batching. They had a whole way that they thought the flow would work. And when they got there, they saw something completely different. So they then revised their model, and they went to nuclear power industry, and they said, how do you apportion putting energy in the grid when you're watching weather patterns change? And then they kept taking it from one industry to another, came up with a framework that's now had dramatic improvements on operating room flow in operating rooms around the country. So the first 30 days, there's a very strict cycle. We, IHI leaders review every 30 days. The team comes in and says, we're making progress or we're not. They revise their model. And people will often ask me, why do I say 90 days? And the reason is because I mean, I don't know what the right answer is, but if you give them 90 months, then they'll take 90 months. I mean, it's a tempo. So if you tell them you're going to have a white paper or a technical brief done by the end of 90 days, they do it. So we've been doing this since 2006, and I included in your slides just some examples of the kinds of 90-day projects that we've been doing. It's a really exciting opportunity. Because they're harvesting ideas, they're learning best practices, they have time to dive down into the literature, they're going out outside of healthcare, and they're creating new models that are making profound differences for patients. So I just wanted to give you an example of how that all works. And then I want to walk you through a couple. The current wave that we're working on right now started September 1st. And we have one that's on quality and safety in skilled nursing facilities. There's not a lot been done about that topic in SNFs and assisted living, so we've got a team working on that. We've got an ACO learning network. How do we help organizations that are trying to form ACOs design new models of care? We're looking at creating a diagnostic tool for cost and quality so that a leadership team can look and say, I have waste here, or I've got a disadvantage one place or another, and it will help a senior team to focus in on the right things as they're looking at cost reduction. We're looking at mental health integration into primary care. We've got some good models around the country, but by and far the problem that you cited is pretty ubiquitous. We're looking at state-level initiatives and especially the exchanges as they roll out. How do we build quality into those so that it's not just an insurance function? And we're looking at how do you structure a quality department? So that's the kind of stuff that we're working on at the moment. But I have a few stories I want to tell you. The first one is about the 100,000 Lives campaign, because this is an example that came out of R&D, but it's an example of something that you in this room could do. It's an example of how a small group of very young people can take some energy and apply it to a problem and solve it. So a few years ago now, Don Berwick and I were sitting in our office, and we were frustrated because I had just come back from England. And there, I could see spread happening more quickly. When I got back to the United States, I could see pockets of excellence around the country, but nobody was spreading anything. It's like there's this tension around learning from another hospital, another academic medical center, or another unit within your hospital. And spread was really difficult. I went and met with the CEO at General Electric, and I said to him, what's your job as a CEO, Jack Welch? I said, what do you think your job is? And he said, my job is the forcible transfer of knowledge. And I said to him, why do you say that? And he said, because it goes no other way. He said, it doesn't spread naturally. So Dawn and I decided we wanted to try and see if we could create a campaign based on, the idea that Jack gave us, which is you have to spread by some kind of a system. And we decided we would try and save 100,000 lives. So where did we get the number? We just picked it out of a hat. But we looked at all of the complications in hospitals across the country. And we said, if we could get 2,000 hospitals to improve 6 things, we did the math on the back of an envelope, and we said, we think we could save 100,000 lives. We really went to our kids, because both our kids work on political campaigns, and we said to them, how do you run a campaign? And our kids said things like, some is not a number, and soon is not a time. And our kids were saying to us, whenever we hear you, parents, talk about improvement, you say, we'll get a little better as soon as we can. And they said, some is not a number, soon is not a time. You have to pick a number and pick a date. So we picked a number, 100,000 lives. We picked a date. We gave the United States 18 months to do it. And then we focused on something that was really important for patients, safety. We made it free. We got some organizations to give us a little bit of funding. But I went out to the IHI staff, and we picked people that looked just like you. There was a young guy named Joe McCannon who was working at IHI. I think at that time, I think he was probably, I want to say 25. Graduated from Harvard with a degree in IT, had gone out to Silicon Valley and started up a little startup right before the crash. So he came back to Boston, and he was working at IHI, working on our computers. And I said to him, would you run the campaign? And he said, okay, because that's how young people are. They said, of course I can do that. So we got Joe a little team. They were all very young people. None of them had worked in healthcare before. And we said, we want you to save 100,000 lives. So we set up a goal. We figured mathematically we'd need 2,000 hospitals. And we said to Joe, if in order to run this campaign, we think you can't do it just this little tiny team. So you need to build a reusable infrastructure. That is, with no money, go out and figure out how you can engage organizations across the country. Most of the hospitals in the United States have no idea who IHI is, but they know the 100,000 Lives campaign. So we said you need to raise the profile of the problem and create a proactive response. So Joe worked with a group of physicians who helped him to create these 6 things. We calculated mathematically that we still had many patients in US hospitals dying on med-surg units. And when you look back, you can actually watch them die in the record a couple of days before, because they were deteriorating without an intervention. And so what we had to do was we took actually from Australia to the point of harvest. There had been one research study in Australia of a system called early warning system. And that was a way to trigger doctors and nurses to get help for a patient that was beginning a deterioration. Now, I teach at the Harvard School of Public Health. Some of you have been in my courses in the summer. And this summer, one of the physicians in the course said, why do you talk about early warning? That's like in every hospital now. If there's a hospital that doesn't do that, then you should talk about them. So this is an example of something that didn't exist in the US and now is pretty much in most hospitals. So we laid out these 6 interventions. And then Joe came into the office and said, I need to buy a bus. So I said, really, Joe? And he said, yes, I need to buy a bus. So I said, could you rent one? You know, he said, all right. So he rented this bus, and he shrink wrapped it in the 100,000 lives. And he said, campaigns have tours. And so I said, okay, Joe. So here we all are, right in the front of the office in front of the Charles Hotel. And we're sending Joe off. So Joe and the young campaign team took off from Boston, and they started visiting hospitals across the country. And I can't tell you what it was like. When they would pull up in front of a hospital, I mean, in some cases, the board of trustees was on the roof, and they would let balloons go. It was like, IHI is here with the bus. It was symbolic, but it said, join me. Come on to this campaign. When we went to, anybody from Wisconsin? When they pulled up to Badger Stadium, they said, when they pulled up to the University of Wisconsin, they said, we're not going to bring you to the hospital first, we're going to bring you to Badger Stadium. And in the stadium, they had taken balloons and they circled 3,000 of the seats in Badger Stadium. How many seats are there? 60,000, I think. It was a very visible clue that you saw balloons around 3,000 seats, and they said, that's how many lives we're going to save in Wisconsin. Every community we went to, they were doing things like this. They were saying, we can do it. We're gonna beat Wisconsin. Every community was different, but each one of them, with their own culture, joined into this effort because it was important, because it was meaningful to patients. We took away all the barriers. It didn't cost money for them to join. And because we had proven that these 6 interventions had worked somewhere. So Joe takes off with the bus, and away they go. There's the bus, and they traveled from Harvard Square to Seattle, and they visited hospitals all across the way, and they engaged people. They created this reusable infrastructure. So this network now, in every state, there were what we call nodes. So every week, Joe would have a call, and there'd be about 75 people on the call, and as soon as Joe would hang up, all those 75 people would call 75 people who would call 75 people, and there was this rhythmic kind of set of communication rules that were developed in the nodal structure. So we have 5 people sitting at IHI managing this infrastructure of communication to reach physicians and nurses and emergency department physicians across the country. By the end of the campaign, the hospitals estimated that they'd saved about 122,000 lives. Over 3,100 hospitals had enrolled, which was a very high percentage of the total beds in the United States. Unprecedented media coverage. Can you imagine how scary it was the day we put Joe on television? Of course, we put Joe on television. But to say, we're going to save 100,000 lives, because there could have been a huge negative press that said hospitals are killing 100,000 people. But the way that we framed it was, join us, we're doing something meaningful and important, come with us and we can do this together. So there was no barrier to entry, everybody came in and was welcome where they started, and it brought all these people together. All of the press coverage was positive. Every local newspaper was going to emergency departments and ICUs in their local hospital, and they were interviewing the doctors and the nurses, and they became the heroes. And so it was wonderful. 55 field offices, that was like the State Hospital Association or a medical society, and thousands on the national calls each week. So the durable lessons from the campaign are these: the power of trying something remarkable, setting out a huge goal, and not being afraid of the scope of the mission that you're putting out in front of people. And I would say getting people who aren't fearful of the scope of the goal. I remember coming to work one day and seeing Joe for the first time in a suit. He mostly all wore clothes like you guys have on. And one day he came in with a suit, and I said, Joe, what's with the suit? And he said, I'm presenting to the board of the American Medical Association in Chicago, and I'm telling them they have to join the campaign. And I was thinking, oh my God, you know, none of us who are older would do that. But Joe did it, and the whole board of the American Medical Association signed on. The value of simplicity, 6 things. Asking someone, can you do these 6 things? The network is a living thing. People had to feel like they had to call in. You know, they had to feel like they were going to get something. That notion of creating something vibrant in living was important. The value of celebration and affection was critical. The love that happened on the campaign was amazing. It had to be a shared story, and we said we were going to avoid consensus. Consensus kills. So we didn't ask anybody, we didn't say we're going to negotiate over these 6. We said these are the 6. If you want to sign on, sign on. AMA, all the major professional associations signed on. But if we had gone through a consensus process, we never would have gotten the campaign up and running. Condensed the timeframes, we launched the whole campaign in 4 months. Everyone's welcome. And then remember, some is not a number and soon is not a time. So we learned, I think, a lot of lessons from the campaign. But mostly what I learned is we can do anything if we do it together. We can do anything if we engage the energy of young people and get them out into the field. But it's not, the spread is going to be a viral thing, and we've got to do it at scale so that we're actually mobilizing people to move and to think about the triple aim of care. So as I want to give you two more quick examples, and then I'll open it up for you. But the idea of the triple aim is to start to think in a totally different way about how do I get into that black circle of integration and begin to think about a different way of care. In the healthcare experience, in the those of you who are physicians, you're going to be thinking about healthcare. And if you're in a public health setting, you might be thinking about the social determinants of health. And how do we bring these together? So I use the WHO definition, the conditions, the determinants of health as being the conditions in which people are born, grow, live, work, and age. And then it says ... including the health system. Like, we're not the prime drivers of health. It's a lot of other things. So I'll often show this diagram to healthcare leaders. And I'll say, these are the determinants of health. Where is healthcare? And then I have to draw a circle so that they can find themselves. Because we are such small contributors to the big picture. And so I think the idea is for them to step back and see, I can't do this alone. I need the army of the campaign. I need public health. I need to think in a very different way about how do I bring all of these people together. And the models of interventions, visits, medications is so weak in dealing with the magnitude of the problem we have that we've really got to start to think in a different way. Who knows what this is? Nobody who took my class in the summer can answer. Anybody? Oh, that is true. Half the time we need to be an expert on something. But I show it for this reason. It's the number of waking hours that a person with chronic disease has to manage their illness in a year. The number of waking hours that my husband, who was just diagnosed with diabetes, he has 5,000 hours in a year to manage his diabetes. He sees his doctor, who's wonderful, but maybe twice a year for 15 minutes. So do you want to place your bets on the 15-minute visit, or do you want to use the assets that Chuck has, which is 5,000 hours? And so the triple aim is saying we need both. We need to work on the experience of care. But if we're going to get Chuck healthy, we've also got to think about that 5,000 hours and create a navigable system so that he's spending those 5,000 hours in the right way. You might have seen a great experiment here. And again, when you ask older clinicians, how can I experiment with doing a virtual visit with an elderly person? Old people say, no, old clinicians say, the elderly they can't use technology, they're too old. And yet in Massachusetts, there was an experiment where a group bought elderly patients an iPad, and they started doing FaceTime visits. And they would do medication reconciliation, as an example. So the patient would sit there, and they would have all their meds, and the patients loved it. Like, they get up early in the morning, put lipstick on, get coffee, because this is like a social event for them. It's a whole interaction on FaceTime. And then when the patient has all their meds lined up and the pharmacist comes on and is saying, okay, let's fill your medication tray. What's that bottle? Oh, yeah, well, that's something my brother-in-law gave me. I mean, they're finding all these things in the FaceTime visit they would never surface in a normal visit. It's happening quickly, the pharmacists are efficient, and the elderly love it. So it's really breaking out of the way that we're thinking and starting to think, for the elderly, there's much more capacity. For Chuck, there's 5,000 hours. And for the millennials, a whole different way to think. So I'm going to ask you to think for a minute about, if you're a physician, you're going to go in, take care of your next patient, and the next patient is a young teenager with diabetes. Now, when I ask the average physician, close your eyes, I want you to stop and think about, what are you going to say to this young kid when this kid now has a lifelong chronic disease? And they get into a mindset of what they're going to say. But I want to introduce you to Trevor Torres and tell you what Trevor thinks.
Hi, I'm Trevor Torres. I have eczema, asthma, I suffer from sleep deprivation, I'm allergic to nuts, but the fun one is juvenile diabetes, or type 1 diabetes. I was diagnosed with diabetes probably like 2 years ago, and I've I used to describe myself as a professional diabetic, except the problem with that is I haven't figured out a way to get paid yet. So until I do that, I like to call myself a diabetes evangelist because I would recommend type 1 diabetes to anyone, and I'll get to that in a second. Just to describe a little bit with my situation, I pretty much do everything on my own. I track my own blood sugar, give myself my own shots, calculate my meals and insulin, and I've pretty much memorized the carbohydrate content of like every food in my house just because of how much I use it. So it's kind of a fun party trick. Like, oh, hey, Trevor, how many carbs are in like this soda? And I'm like, it's 42 for one can. And I would definitely recommend diabetes to everyone for two reasons, mainly, although there's a lot. I'm not going to list them all. One, it's so much easier to be healthier if you are a type 1 diabetic because you're already looking at all the nutrition facts on your foods anyway. So I think that a lot of the diet problems people have is just because they kind of unconsciously eat something bad. They're like, oh, they look at their day or whatever and they're like, oops, I probably shouldn't have eaten like that many cupcakes or something. And another thing I really like about diabetes, I feel like it makes me more confident. It's like, and this might be a little irrational, but it's like any accomplishment I have, I feel like is that much cooler because I have diabetes. So I accomplished this thing and I had diabetes at the same time. There's two main things. One, don't condescend. Especially for me, I don't really like that because I am one of the smarter patients, and so I guess I could have said stay out of my way, but that doesn't really help very much. When I was first diagnosed with diabetes, they were like, you can give yourself insulin in one of two ways. You can do it based on your blood sugar. If you have higher blood sugar, give yourself more insulin and so forth. Or you can do it based on what you're going to eat. If you're going to eat X amount, give yourself X amount of insulin. And I was just like, well, that doesn't make sense. Why don't I just come up with an algorithm that incorporates both variables? So again, that's probably a little atypical, but if they already have something figured out, you don't necessarily need to lower the level of your explanation down to what you perceive your patient's level to be. You can explain something, and then if your patient doesn't understand it, they can ask, for clarification. Now that may be just me, but I really hate it when I feel like I'm being talked down to. And that also might be my age. I know we kids are a little upstart about that. So it's like, another thing that I hate is never say poke. I'm going to poke you. Like, no, you're not going to poke me. You're going to stab me. Okay? A poke is where you prod someone with your finger. A stab is where you insert a sharp metal object with the intent either to inject a foreign substance into the body or to draw blood by breaking the skin. Little rant there. Another thing that's important is to understand how your patient learns. And I don't have all the answers here, but I know that for me, I really like to know why something's being done. Like, if a doctor just says, you need to eat this way, you need to do this thing, take this treatment, anything. If they tell me to do something, they better tell me why I have to do it. Because one, that way I know I actually should do it. Because people tell you to do things all the time. And if I did everything that I know I should do, I would not have, I don't have time to do that. Ain't nobody got time for that. But if my doctor says, you need to take this medication because this is what it's going to do scientifically in your body, this is what's going to happen if you don't do it, this is what's going to happen if you do, then I know exactly why I should, and then I'll be much more likely to do it. If somebody is like, if a doctor is complaining like, oh, my patient didn't do X, Y, and Z, and then you didn't tell them why, you just told them to do it, well, of course they didn't do it.
So, I know, isn't he great? So when you think about it, most physicians tell me that they feel like they're going to console Trevor because he's got this chronic disease, and they're going to very quietly and slowly explain what Trevor should do. And then all of a sudden, Trevor appears on the scene, and there's such a mismatch between the design of the care system we've got and Trevor's needs. And I think this is where we're headed. So I'm going to tell you one more story, and then we're going to open it up. And that is so we've got elderly patients on FaceTime. We've got Trevor saying, don't poke me or stab me or whatever. But Trevor's got a whole website now of all these young kids who love being diabetic. They love it. They said, we are the healthiest kids they know because they have diabetes and because they're taking care of themselves. And it's amazing to hear them. They all sound like Trevor. It's not just a one-off. And then I'll introduce you to one more patient, and this one's Christian. So I was in Sweden and at an academic medical center. So it looks, for the most part, just like the academic medical centers that many of you work in. And I was walking through the hospital, and I came to a weird unit that I'd never seen before. And I'm in hospitals every week. So I walked into this place, and I said, what is this place? And they said, this is the patient self-hemodialysis wing. Now, I know patients do their own hemodialysis. They do their own peritoneal dialysis. I know they do it at home, but I've never seen a hospital build a wing where all the patients take care of themselves. So I said, well, how did you come to build this building and say to the patients, take care of yourselves? And they said, we're very innovative. We've been working with IHI for 10 years. And I said, no, really. That would never happen. So they introduced me to Christian. Christian Farman was a mechanic at Saab Avionics. And he came down with glomerulonephritis and ended up on dialysis. Now, he's a mechanic. So after a few weeks of the dialysis, he said to his nurse, you know, I think that I can do that. Will you teach me how to do it? So she did. She started teaching Christian how to do his own dialysis. And then Christian taught the 73-year-old lady in the next bed. She was saying, Christian, what are you doing? And he said, well, I'm doing my own. So the nurse and Christian taught her how to do it. And then they started to teach others. So I spent a few days with Christian. And I said to him, tell me about this. How did all of this come about? They now have an aim to have 75% of the patients in their academic medical center doing their own dialysis. They're up to 70% when I was there in Sweden a few weeks ago. So I said, Christian, tell me why you felt like you should do this procedure yourself. And he said, he did research. He said, I'm a young guy. I want to get married. I want to have children. And he said, my whole life is consumed by dialysis. And then he said, I'm chronically underdialyzed, so I end up with post-dialysis syndrome. So I go from this bed, home to bed. I have no life, and my chances of getting married and having kids are small. Now, Christian, after taking over his own dialysis, got married just a few weeks ago, so I'm very happy for him. But he said, I want a full life. And he said, I want to be able to work. I want to be able to live. And he said, I'm not now. I'm in a total chronic care model. So I said to him, but Christian, what about safety? And he said, of course the care is safer in my hands. That wasn't what I was expecting. I thought he was going to say, oh, you know, I can always call the nurse, or somebody's always around the corner. But he said, first of all, I always do it the same way. Every one of you does it a different way. And second, he said, it's my bacteria, not yours, that I'm injecting. So he said, and complication rates have decreased dramatically. So I said to Annette, the head nurse, why did you decide to go to the CEO and say, I think we should build a building for all these patients? And what she said is that if you have half the patients taking care of themselves and the other half being cared for in a unit, then you're never going to get the economies of scale. She's saying, if I want to get the financial part, the cost per capita down, I have to segregate them so I can staff it differently. So she said, she went to the CEO and said, now we've got X number of patients every day who can dialyze themselves. And the CEO looked at the business case and said, we're going to build this building. Annette was designing the building, and she one day heard a knock on the door, and it was Christian. And he said, what are you doing? And she said, I'm designing the new dialysis building. And he said, how are you going to make it look? And she said, I'm investing a lot to make it look like home. And she said, there's going to be warm paint and nice lights, and I'm investing a lot in comfortable lounge chairs. And he said, it's a hospital, goddammit. I don't want it to look like home. I want it to be convenient. And she had totally misread the reason for him wanting to do his dialysis himself at the hospital. He said, it's socialization. I'm isolated when I'm at home. It's inconvenient. I have to get my water supply filtrated. I need to get supplies delivered all the time. He said, it's much better for me if I do it with others here at the hospital. So she invested the money, but in very different things. And these patients, every patient on this unit now, either gets dialyzed while they're exercising, or they come in early and exercise before they dialyze. Now, your homework is go look at the dialysis units in your hospitals. They don't look like this. They're patients with white sheets up under them, with their little trays being delivered to them. And in the most innovative ones, and I've been in dialysis units now from Vancouver to New Zealand, the most innovative ones, they say, oh, we give iPads to the patients so they can watch movies while they're being dialyzed. They're treated like they're sick. And when I said to Annette, what do you do now if you're the head nurse of a unit where all the patients are taking care of themselves? She said, the first thing I do is, when a patient gets admitted, is I sit down and I help them write their CV. And then once a month, the County Employment Bureau comes in, and she said, anybody that wants to go back to work, I help them go back to work. She said, that's what matters to the patient. It isn't, having an iPad to watch a movie while they're being dialyzed. It's they want to live. And that's what's possible. Now, when you go visit your dialysis unit, you ask the head nurse, how many patients on your unit are working? They won't know. The care ends at the end of the interaction. Your point about navigation, we've got to navigate them back to what matters to them, which is work. So I said to Christian, did you go back to Saab? And he said, no. I said, oh, that's too bad. I was thinking this was a failure. He said, I'm an RN. He said, I'm now the head nurse of the ENT unit in the academic medical center. He said, I was here all the time anyway. I got interested, so I went back to nursing school. So this is what we can have when we stop saying, what's the matter? And we say, what matters to you? And then we redesign care. This is the kind of innovation that our patients are needing. So now they've got dialysis at half the cost, complications are dramatically reduced, and they're measuring their success by the number of patients working. So this is a group of physicians and nurses from England who went up to learn. That's Christian in the blue jacket, and Annette, the head nurse, is with the checkered shirt. So now a head nurse on a unit and a patient are now the teachers for these physicians who have gone back to England, and they've got a 3-year plan to create all the patients doing their own dialysis, anybody who's physically capable. And now we're starting to see that spread in the United States, but very slowly. It's going to take people like you who are here in the iLab to say what matters to you on a population level, and then create totally new models of care, thinking about the assets, the 5,000 hours Chuck has, thinking about Trevor and his knowledge and capability and competency at managing himself, and thinking about the assets of Christian. So let me stop and turn it over to Alexi. No, I'm only kidding. Thank you. And so, questions or comments, please.
So this sounds really, really great. Thank you so much for being here. The one question I had was, who funds all of this? And it seems like there's a lot of cost to start, to get it started. And I know that some people are probably not going to make money if not that many people are needed for dialysis, for example. So who actually supports it?
So a lot of the work that IHI does is, remember I showed you that graph of the concentric circles with the R&D in the middle, and then the partnerships. IHI funds all of the R&D, so we're funding all the model development. People pay us to be their partners. People pay us to come to the seminars, and then the outer ring, WIHI, and the open school is all free. So we're using money from these two rings to fund innovation and spread. Now, in a hospital, they had to figure out, how are we going to fund this dialysis building? But when you look at it, if you can cut down the cost per care and complications, you can actually increase throughput. There's much less staffing on the self-dialysis unit, obviously. So once you get those patients aggregated, then you can manage that at much lower cost per case, which is going to pay for the building. it's the reason why I'm so excited to be here is because you need the clinical expertise to say, yes, this is possible, and you need the business expertise to do the modeling that will show people what the net result is going to be as you move money from one pot to the other. Yes?
I'm wondering if with the triple aim being a paradigm shift in terms of how we think about this world of healthcare and everything that's involved in it, I'm wondering if there's going to be more of an importance on connectors, people who think horizontally, and sort of can see, maybe they're not an expert in one given area, but they can sort of see how health pertains to care, pertains to cost. I'm just wondering if you could sort of discuss what you think about that.
Yeah, I think it's a very good question. I think it's the intent of an ACO, an accountable care organization. The intent is, if we structure someone to take on all three aspects of the triple aim, and they have to partner, a hospital with medical practices in the community, with social workers and the like, what you start to see is people saying that I need a different structure, I need a connection structure. What's happened in reality in this early part of ACOs is that the leaders are all focused on the legal structures. Can I buy up a bunch of group practices? Should I open up a bariatrics clinic? Should I, it's all the acquisition of assets. And they're not really yet thinking about the models of care. I think that's going to be the real challenge for us. But that's what we're doing, is we're building these models across chronic diseases and across acute situations. So, yes.
Thank you. It seems like most of the things you've talked about from IHI are more involved in process changes. Is there anything in terms of technological changes that you guys do, or how do you guys kind of implement technology with some of all these changes? And then the second question, it seems like a lot of the barriers today in healthcare is, hate to say the physicians or the structures. Physicians are a lot, maybe not just physician, but the structure today of healthcare is not really open to innovations.
Yeah.
So what are you guys doing in regards to that?
So I think you're absolutely right about the structure. I mean, it's why we started the open school, to try and get students, physicians, nurses, healthcare administrations, pharmacy students, to be empowered to think, I could work on a campaign, or I can help Christian to restore his life. But the educational process still teaches, except in a place like this, you're still learning for the most part with your own profession, and you're learning that kind of interaction on one-on-one with the patient. So we're probably not as great at IHI on integrating technology as we will be. We're starting to work with some of the big data labs, and with John Moore, who's looking at how do we integrate things like the FaceTime, iPad into the process changes. I think we haven't even begun to touch that yet. But you're right, I think the current structure does stifle innovation. And it's why I'm so delighted to be here, that you've got all these different, how many of you are physicians? And business students? Why are you all at the back? Yeah. If you guys could take on a project together and figure out that you could create a self-dialysis center, or you could run a campaign, we desperately need that integration of where is the money flow going to change, because some people will lose and some people will win, and we need that map in order to understand the resistance before we take something on. So I think we've got lots of work to do there.
Given the demographics in the US and in Europe, it seems that the cost per capita factor will become increasingly important.
Yes.
So just a question to you, say that if the next 10 years or the next 15 years, we will have to cut to half the cost per capita, can we sustain the same level of health and care in the US and Europe?
You know, I think what we'll see is in some places we will see care even get better. And in some cases where people don't make the right decisions, we'll see care get worse. And what I mean by that is there is 30–40% of our cost is waste in the United States. Even in some of the other countries in Europe, the same thing. We see tremendous waste. if a leader takes the right decisions and they say, I'm not going to cut nursing staffing in half on Christian's unit, but I'm going to empower the patient to do their own care, you're going to see better outcomes at a lower cost. And there are leaders who are that visionary, but there are also leaders who are going to take the wrong path, I would predict. And that is the easiest thing is just to cut the budget. And that they'll cut staff, and they're going to see complication rates go up. They're going to cut supplies, and you're going to see infections rise. And I think I hope that we're not headed for a system where there are two levels of care, but I'm convinced that we've got models where we can drive cost out and sustain quality. I'm very hopeful about that.
I just wanted to ask, what sort of research and development is the Institute for Healthcare Improvement doing on prevention?
Oh, we've got a whole, we've got every single one of these 90-day cycles includes something on prevention. And so we're working on the health of populations. We're looking at, I'm about ready to replicate a project that we're doing here, here in the United States that we're doing in Scotland. And this project is called the Early Years. And the project that we've been running in Scotland is intended to make Scotland the healthiest country in the world in which to grow up. Do we have anybody from Scotland here? Yay. Where are you from?
I'm from north of Aberdeen.
Uh-huh. So do you know the Early Years Project?
No, I haven't heard of it.
Yeah. So we started working in Scotland a few years ago on safety. And then we just launched this in January. And the project is to make, to decrease the Glasgow effect.
Okay.
And the Glasgow effect is the gap between life expectancy between the higher and lower socioeconomic parts of Glasgow, one city. The life expectancy parts of Glasgow is 52 for men, 52. The gap from one part of the city to another is over 20 years. And so what we're trying to do is create health by making this, it's all prevention. So we've got 3 parts to the early years. The first part is conception to 1 year old. And that's about creating healthy birthing processes and attachment mothers to babies. I've been in many drug and alcohol clinics in Scotland, and when you see the parents, they just keep having children and they keep getting taken away. We're breaking that cycle. The second part is 1 to 3, and that's about creating attachment. And as you know, attachment is the #1 predictor for children to be able to be healthy. So it's creating attachment with a healthy adult from 1 to 3. And then from 3 to 5, it's preparation to learn. So you might not say that that's prevention because it doesn't look like stuff that you do in a doctor's office, but it is amazing. And just a few weeks ago, I was over in Perth, and I brought a group of hospital CEOs over, and I said, we're going to learn how to do prevention for an ACO, for a population of children. And so we walked in, and the first place that we went, they were expecting we were going to go to a hospital or a clinic, and the first place we went was to a school. And the faculty were 16-year-olds and 14-year-olds teaching hospital CEOs from the United States how to do exactly what you're saying. And they said they use PDSA cycles, they use quality improvement tools, these kids, and they said, well, the first thing you have to do is you have to set your academic goals. And so they said, you know, everybody's different. You're good in math, you're good in science, I'm good in history, but we have to set goals to grow academically, and then they use quality improvement methods. But they said that's not enough to achieve academic goals. They said you also have to become healthy. So every kid has got to join a sport, and they run PDSA cycles to improve in their sports. Some are swimming, some are playing golf, some are running. But they said you've got to be healthy, and so they're running improvement cycles on that. And then the third thing they said is you've got to develop yourself intellectually. So every kid sets a goal, an intellectual goal in the arts. Some of them are acting in plays, some of them are learning photography, some of them are writing poetry. But they said a whole human being has quality improvement projects in all 3 areas. And when I think back to the United States, what are we doing in our schools? Cutting out gym, cutting out anything that has to do with arts or extracurricular activities, and focusing only on can you accomplish your MCAS scores. And so this project, I think, desperately needs to spread across the United States. Are we okay to keep taking questions? Or?
Yeah, a few more questions.
Okay.
I was just curious if you could explain just the basic goal or mission of IHI and then just the long-term vision of the organization.
So our mission is to improve health and healthcare worldwide. So the mission is huge. And our long-term vision is that we will have partnerships with other IHI-like organizations around the world so that we can stay small and leveraged, come up with new ideas, come up with new models, harvest best practices, and then just like that nodal network happened for the campaign, that we'll have a similar network of other organizations like IHI. And those will then, we can call and spread these ideas very quickly. Next week I'll be in Alaska working with the Native American population, and the week after that in New Zealand working with the Maori population. But both like-minded organizations, so if an idea comes from R&D at IHI, I can deploy it very quickly around the world. Yes?
I've got one question regarding Christian story. When you make patients like more powerful to take over their own role in healthcare, what is the role of the insurance company? Like for me, I saw in different areas in Germany that when you have models like this, for some time insurance companies are very happy because they pay less and they are willing to pay a little bit more. But usually after 4 or 5 years, they say, hey, listen, you really save a lot of costs and now your premium will be adjusted for this. So how does this work worldwide or in the US right now?
I think the exact same thing will happen. What we'll see is the insurance companies will pay a little bit of a premium for a bit, but we're moving to a bundled payment. We're moving to a new payment mechanisms anyway. So you've got to get the cost out anyway. And then I think that's what we're hoping actually. Although people right now would never say this out loud, we're actually hoping that costs will come down. That's the answer to the problem that we were talking about here. So I think that it's actually a good model to give people a little bit of wiggle room to drive down the cost while they're improving the experience of care and health. And that's, I think, the sanest way for an insurance company to act. We're seeing that in Massachusetts with the alternative quality contract. Very similar model.
Hi, firstly, thanks for walking us through a couple of your cases. I had a question around implementation, and could you speak to some of the different approaches you use to pull through these ideas after 90 days?
So what we'll often do is we'll convene what we call a collaborative. And so we'll get organizations that are, the lowest dose is the campaign. And Alexei Nazem, where'd you go, Alexei? Alexei worked on the campaign. So he's the expert that can tell you how campaigns worked. He was there from the start. How old were you when you started working on the campaign? 23. So he was 23 and he worked on the campaign for 2 years. How many, you must have visited, I don't know how many states. 41 states. So Alexei was out there, and what he was doing was going into a hospital, provoking them, giving them the change package in terms of a how-to guide, calling them on the phone each week, and prompting implementation that way. Other times when it's a more complicated intervention, what we'll do is we'll create a collaborative. And we'll have teams come from each hospital and they'll meet every couple of months. They'll submit data. They'll get coaching on the phone. So the dosing of the intervention for execution depends on the complexity of the intervention.
Okay, so just building on your question, Matt's question, I'm curious as to how you guys actually do end up achieving scale, because it seems like you've talked about a lot of really, really interesting innovations that I think a lot of us who are in this space have never actually heard of. So just wondering how you guys go about achieving scale and sort of spreading innovations. It seems like, is this through sort of academic medical centers where you go out, or how do you actually go about reaching sort of more one-off clinics, sort of rural areas where a lot of care actually occurs? Just what are your tips in actually sort of taking these innovations and scaling them?
Well, it's a great question. In part, we use the same network. So we just had the CMS, Medicare, called IHI about a year and a half ago, and they said, can we use your network? And they said, we want to decrease infections for patients with hip and knee replacements. It's the largest growing procedure in the United States. So we just did an experiment where we put all the new knowledge right into that same reusable infrastructure, started up the monthly calls, and the states that used the network got much better results. Sometimes it's deployment through the web. This WIHI radio show, and it's free, and a small clinic or a rural hospital can listen in for free. They can download the podcast, or they can go onto the website and get this knowledge. So I think there are lots of different vehicles, and there are so many different kinds of healthcare providers just in the United States. In other countries, we often have a more structured approach because there is a system. Here in the United States, we don't have a system, so we've got to make it up by creating a network.
Well, if you guys can all join me in thanking Maureen for coming tonight. Thank you.